Hey guys, welcome to Gross Anatomy. This will serve as really one of the first lectures for the course. Don't want to make the assumption that we've all had an anatomy and physiology experience that was similar. So I'm going to start with just some baseline terms, definitions, that we'll use throughout the course during dissection and that you will read specifically in your dissector more than likely, so that we're all on the same page. So this will be like kind of like building the foundation for the terms that we'll use throughout the course. The first term that we're going to come to is the anatomical position. It becomes important to know that the anatomical position is that position in which your patient is standing erect with their palms facing forward. So in other words, their palms are going to be in a supinated position. A lot of times we make the mistake of assuming that the palms facing towards the thighs would be anatomical position, but that just truly isn't the case. This position, the anatomical position, is the standard reference point in which all position, movements, and planes are described. So please make sure that when you are describing things to me, you are referring or using as a reference point the anatomical position. As I already mentioned, there are different anatomical planes that movements can occur in. And so when we think about anatomical planes, one of the first things that we want to think about is, what are they? And so the way that I kind of define anatomical planes is I define them as these fixed lines of reference along which the body is often divided or sectioned into to facilitate viewing of different structures, right? And we can think of this like in an MRI or a CAT scan, where you have different segments of the body being looked at to determine at what level the injury is, in which part of the liver the defect occurs. So it's almost like this layering of the body. They also allow one to obtain three-dimensional perspective, right? And so that's the beauty of the anatomical planes. There are three different anatomical planes that we'll kind of talk about today. The first one is the sagittal plane, and I'll define it a little bit later, but this is the sagittal plane here. The next one is the frontal or coronal plane, and then the last but definitely not least, and probably most important, would be the transverse and or horizontal plane. So first we'll define the sagittal plane. We think about the sagittal plane, we kind of want to figure out, okay, well, what is it and kind of what does it do, right? Why is it important to us? Well, the sagittal plane kind of divides the body into right and left portions, as you can tell here. And so when we think about movements that occur in the sagittal plane, what we're going to be thinking about is this idea that movements of flexion and extension, dorsiflexion and plantar flexion, those would all be movements that occur in the sagittal plane. So again, sagittal plane cuts the body into right and left halves. We have movements of flexion and extension and or dorsiflexion, plantar flexion at the ankle. And this kind of goes back to that 3D view of the human body. In the sagittal plane, what we could imagine is that as the MRI machine is, let's say, imaging this patient, we'll be able to view all of the different slices of the patient in the sagittal plane. So it's just a beautiful depiction of how an MRI or a CAT scan actually captures each piece of the patient in their respective planes. Next plane of motion is the frontal plane. The frontal plane divides the body into basically anterior and posterior halves, or front and back halves. It is also called the coronal plane, and the movements that occur about this particular plane of motion are going to be movements of AB or abduction and AD adduction. And so we can again see, if we're looking at it from an MRI perspective or a CAT scan perspective, we can again look at different layers of the anatomical structure that we are looking at. And the last plane, but I think probably one of the most important planes, is the horizontal or transverse plane. Horizontal or transverse plane is going to divide the body into basically upper and lower halves. And again, it can be called horizontal and or transverse. And again, if we're looking here, and if we're looking at maybe an MRI, what is awesome about this is we'd be able to see each layer of the patient so that we don't miss anything. Most important, probably in the knee, where you can actually look at the different layers of the femur, or the tibial plateau, and you can also get a different perspective on an ACL injured or ruptured patient as well. So I think the transverse plane really tells us a lot of information about most of the anatomical structures in the body. Next, we have anatomical axes or axis, which are completely different than anatomical planes, so they should not be confused. An anatomical axis is a straight line about which an object will rotate, right? And remember, we said that an anatomical plane is a fixed line of reference along which the body is often divided. So an axis is a straight line around which an object rotates, and a plane is a fixed line along which the body is often divided. So they're completely different concepts. The axis or axes of the body are going to be kind of perpendicular to the respective plane of movement. And so what we can say is that movement at the joint takes place in a plane about an axis, right? And so there are 3 axes of rotation. And so let's just kind of break those down a little bit. So the first one that we have is the transverse plane. Second one is the vertical, and sometimes it'll be called the longitudinal axis. And last but not least would be the sagittal axis. Please note that in red are the axes and in blue are the planes. Again, just for review, a plane is fixed lines of reference along which the body is often divided and allows us to view different structures. And then an axis is a straight line around which an object moves. What we know about planes and axes is that there is a great relationship between the two. In other words, movement at the joint takes place in a plane about an axis. So let's go to the next slide, and hopefully this will kind of bring it home for us. So I'm going to go green first. In the sagittal plane, sagittal meaning the body's cut into right and left halves, about the frontal axis, what we have occurring in that plane would be flexion, extension, and we could add in dorsiflexion and plantar flexion as well. In the longitudinal axis or vertical axis and the transverse plane of motion or horizontal plane of motion, what we have in that particular plane occurring is most of the rotary motions, right? Or combination movements about a joint. So for example, internal, external rotation of the hip, internal, external rotation of the tibia, and then also internal, external rotation of the glenohumeral joint. If we wanted to go down to the foot and the ankle, we could say supination and pronation. Those would all occur about the longitudinal axis in the transverse plane of motion. And then last but not least, we have the frontal plane of motion and the sagittal axis. In the frontal plane of motion, abduction and adduction all occur in the frontal plane about a sagittal axis. So really what you want to do when you're thinking about movement that's occurring, you have to consider both the plane of motion and the axis of rotation. And then you have to know which movements actually occur in each of those planes and axes, okay? So let's kind of make this more clinically applicable. If we were to look at the following motions here on the slide, right? The cartwheel, the back somersault, the head spin, the pirouette, side hops, split, and a front roll, what plane of motion would we say that these actually occur in? So cartwheel, probably going to be predominantly frontal plane, right? A back somersault, for the most part, will be sagittal plane. And then we can kind of go down this list, and what we're doing is describing the motion in terms of its plane of movement. Hopefully that makes sense for you all. We'll do this in class a little bit. Describe the following motions in terms of its plane of motion and now axis of rotation. So the plane of motion for shoulder flexion extension, right, is going to be sagittal, but it's also occurring about a frontal axis. Hip abduction occurs in the frontal plane about a sagittal axis, and then head rotation occurs in the transverse plane about a longitudinal or vertical axis. So this is the way that when you really describe movement, you should describe it in terms of its plane and its axis, if possible. So here's the interesting part. We've talked about planes independently. We've talked about axes independently. But the reality is that our bodies, we as humans, always most often move in more than one plane at a time. Most often, we're really spending most of the time probably in the transverse plane of motion. So the question is, which plane of movement is usually neglected in training? Hopefully all of you are clinicians in this class. You would say that really truly the one plane that we neglect probably is most often the transverse or horizontal plane. So the plane where rotation is occurring most often. Most often we try to isolate movements during training. That isn't all of you in this class, but what we tend to see is lots of movement, lots of rehab, lots of exercises that are designed to create movement in the sagittal plane or the frontal plane. And a lot of functional therapists now are starting to integrate rotational aspects to their actual rehab program. So it's nice to see that the transverse plane isn't as neglected as it once used to be. So that is the summary for both anatomical planes of movement and axes of rotation. Now what we're really getting into is the terms that we're going to use in dissection to describe movement, etc. So the first terms that we come to are common terms in dissection, and your dissector will use these terms throughout the entire text. So it becomes important to kind of just know what you're saying when you're actually saying it. When we say we are dissecting, what we're saying is that we're dismembering a body, and we're doing that for academic purposes. So really, honestly, you should be taking pride in your work as you begin the dissection. You should really have fine, clean work when you're doing this, because then what happens is it aids in your learning, and it just makes the whole learning environment that much better. When we say we're making an incision, what we're saying essentially is that we're cutting into skin or flesh of a patient. And most often the incision is done with a scalpel. And quite honestly, the only time we incise our patients is when we're actually making skin flaps. And that will be the only time really that we make an incision into the patient. Other terms that you're going to hear me use a lot are what the idea of transection or to transect. What that means is you're cutting something into two in the transverse plane. And so a lot of times what we'll do is we're going to be transecting a lot of the muscles from either their proximal or distal attachments. So we're going to be cutting them away. And what we're going to do is we're going to reflect them. We're going to fold them back. And the idea is that with reflection, we can see, observe deeper anatomical structures. I think if of all the definitions, the one thing that you will do the most is you will clean. Cleaning is an art that you will learn, that you will come to love, have a love-hate relationship with. You can either bluntly clean or sharply clean, or aid in sharp dissection. Again, this goes back to that dissection toolkit. The blunt dissection, you'll be using the blunt probe, and then for your sharp dissection, you'll be using the sharp probe to do that. Again, we don't do sharp dissection very often because what we find is that there's just compromise to the anatomical structure. So make sure you're using that blunt probe. And then last but not least, sometimes what we'll do if we don't reflect, we'll retract. Retract means you actually just, you don't transect an anatomical structure, you just kind of move it or pull it over to the side so that it allows you to actually view a structure. So in your dissector, sometimes it's going to say transect and reflect, or sometimes it's going to say just retract it. If it tells you to just retract it, you can use that awesome hemostat to kind of grab hold of that anatomical structure and then to pull it or move it over so that you can view deeper structures in dissection. So those are our dissection terms. Now what we're going to do is talk about positional terms and directional terms. The first four terms that we're going to talk about, hopefully, are reviewed. So prone means that the cadaver will be lying in a face down position, and then supine means that the cadaver will be lying in a face up position. In other words, there will be times where we have to move the cadaver from a prone to a supine or a supine to a prone position, and this will require the work of the entire team because the cadavers are relatively heavy. We also will use terms such as unilateral or bilateral. Uni obviously refers to one side, so pertaining to one side of the body. And then bilateral, what we would say is it pertains to both sides. So let's say a patient has hamstring inflexibility. Is it unilateral, only on one side, or is it bilateral? And then how does that drive our treatment paradigm, etc. Other terms, these are going to be directional terms that are important in the class. So when I walk over to your group and I ask you to describe what you have or where it's in reference to another structure, you should be able to use these anatomical terms. My expectation, in fact, at the grad level is that you would be using these terms. So the first term is superior. It's a term used to describe a place that is towards the upper part of the body. Most often, if it's towards the skull, then we would use cranial, but we really use the term superior. So anything that's moving towards the head that isn't a limb, you should be using the term superior to describe. And then when we talk about something that's in the lower part of the body or something that's below something else, then we use the term inferior or caudal. And so again, we really want to be specific. Is it superior? Is it inferior? The other terms that we use are lateral and or medial. So remember, we talked about this anatomical position, and so now it becomes very important because when we think about something that's lateral, what we're essentially saying is that it's towards, it's away from our midline, right? So if we were to draw a line straight down the middle of our body, like the sagittal plane, for example, anything moving away from that midline would be considered lateral, and anything moving towards the midline would be considered medial. And we'll kind of give examples of that in lab as well. Two other terms are anterior and posterior. It's used to describe either the front or the back of the body. When you refer to something that's anterior, it's describing something on the front part of the cadaver. And then if you use something, if you're trying to describe something on the back side of the patient, then that is something that is on the posterior side of the patient. So an example I gave was the sternum or the chest is anterior to the actual spinal column, and then vice versa, the spinal column is posterior to the chest or the sternum. Proximal and distal often get confused with superior and inferior, so I wanted to be very clear in this description, and that's kind of why I put this white box here. These terms are only used when discussing limbs, so not any other anatomical structure. Proximal means closer to the center of the body. For example, if we think about the shoulder joint, it is proximal to the hand, right? So if we were looking at the hand and we're describing the shoulder joint in relation to the hand, we would say that the shoulder is proximal to the hand. Distal means away from the center of the body. So in relationship to the shoulder, we could say the hand is distal to the shoulder or distal to the head, however you want to describe that. Again, when I come around to your groups, this is how I want you speaking to me. Speak to me like you are a gross anatomist. Other terms to describe would be ipsilateral versus contralateral. Ipsilateral means on the same side of the patient or reference point, whatever it is that you're referring to at that moment in time. And then contralateral means on the opposite side of whatever it is that you're referring to at that point in time when you call me over to ask a question. So again, please use these terms. We have the term superficial and deep. Superficial refers to anything on the surface or the exterior, and then deep structures are those that are inside of the actual patient. So we can also just think about things relative to where they lie. So for example, a structure that's closest to the surface of the body would be superficial, while a surface that's further away, a structure that's further away from the surface is considered deep. An example of this probably would be something like the rectus femoris muscle, which is in the quadriceps, is superficial to the vastus intermedius, right? However, the vastus intermedius, which is the deepest quad muscle, is deep to the rectus femoris muscle. Okay, in class, what I want you guys to do is give an example of the use of the following terms in relation to body parts, bones, and muscles. So I'll give you an example. The patella is blank to the scapula. So would you say the patella is inferior superior, caudal cranial? Would you say it's proximal distal, medial lateral, superficial deep, ipsilateral, contralateral? What would you say the patella is to the actual scapula? Most people probably would say that the patella is either inferior or caudal to the scapula, or since we're referring to a joint and not a limb, so yes, it would be inferior or caudal. Okay, quickly, let's go through movements. Flexion is bending of a joint or decreasing the angles between two bones. Most often, we can see that in elbow flexion, like the patient is doing in this particular image, but also knee flexion, plantar flexion, dorsiflexion, actually plantar flexion, knee flexion, and elbow flexion or shoulder flexion. Extension is the opposite of that. It's increasing the angle between two bones or straightening a joint. So elbow extension, knee extension would be common movements. Hyperextension, or what I call is kind of genu recurvatum or recurvatum, is excessive extension at the joints beyond the normative values and or range. Okay. So here is already what I've described. You can have wrist extension, wrist flexion, shoulder flexion, shoulder extension. It becomes important to kind of know what the normative values are for each of these motions at each of the joints. Other movements would be adduction. The way I think about it is you're adding to the body. So it's a movement of a body part towards the midline. And then abduction would be the opposite of that. You're moving the body part away from the midline. And most often abduction and adduction occur at the glenohumeral joint and then also at the hip joint as well. Then we have kind of what I would call our combination movements, right? So you have turning of the pronation would be turning of the arm and or the foot downwards. So I kind of think of it in the hand as emptying a can. And so the palm would be down, facing down towards the ground. In the foot, right, what we would say is that pronation occurs when the foot is kind of placed in a foot flat position, right, or the calcaneus kind of everts a tad bit. Supination is the opposite of that. The palm is facing forward, and then in the foot, what I would say is that the foot becomes a rigid lever and more of the pressure is being placed on the lateral outside, on the lateral side of the foot. So we've got supination in the hand, which would be a full can, right? And then we have supination in the foot, which means that patient is, at least in the initial contact of gait phase, kind of on the lateral side of the foot. The foot's a rigid lever and you have calcaneal inversion occurring about the foot. Other anatomical terms, retraction and protraction. You can kind of see in the patient at the top of the screen, retraction of the neck would be pulling the neck backwards, and then protraction of the neck would be pushing the chin forward. And we can also think of retraction and protraction in the shoulder, right? If we were to punch our shoulders outward, that would be protraction. If we were to pinch our scapula towards one another, that would be retraction. And then we have also elevation and depression. So elevation, I kind of don't think of as the head, but at the shoulder, we can raise our shoulders, right, and kind of do a shoulder shrug, or we can depress our shoulders and move them away from our ears. You can also do the same with the mandible, right? Elevation would be kind of squeezing your lips together, and then obviously depression of the mandible would be opening your mouth. We've got rotation. So many different types of rotation can occur. I've already said this in the lecture. Internal, external rotation. Circumduction, you can have that occur at the hip. You can have it occur at the glenohumeral joint. Just depends. And then we also have internal, external rotation as well. So rotation at the head, and then we have internal, external rotation that can occur at the knee, the hip, and the glenohumeral joint. Lateral flexion is a term that we don't really use very often, but it's flexion from to one side or another. Most often it occurs in both the head and at the trunk. And then we would, at the hip, it really is called abduction and or adduction. Other terms that we will use a lot in lab are things that I think are a little bit more common to you all, but inversion and eversion of the foot. And so inversion is bringing the sole of the foot inwards, most common mechanism of injury. Eversion is bringing the foot outward, specifically the calcaneus, and so that's the least mechanism of injury for an ankle sprain. Then we have dorsiflexion and plantar flexion. Dorsiflexion would be bringing the toes to the shin, and then plantar flexion is moving the ankle downward. In other words, it's like pressing on the gas pedal. At the wrist and the hand, we have a few different movements. We have radial deviation. So any movement of the wrist towards the radius side or the lateral side of the hand would be radial deviation. Any movement of the wrist towards the ulna or the medial side would be considered ulnar deviation. And one of the reasons that we are human beings and we are different than, let's say, apes is our ability to oppose or to create what we call opposition, which is movement of the thumb across all of the different fingers. That is one thing that separates us. So that is the end of our slideshow. I hope that I didn't go too fast, and I hope this was a review. My expectation is when you walk into class on Tuesday that you would be able to speak the gross anatomy language to me. Looking forward to this summer with you all. Looking forward to learning and going deeper into the anatomy of the human body.